The greatest challenge for biomarker testing remains tissue stewardship, using it well, using it right, increasing complexity with more and more things to be tested for docs to keep track of, and the increasing complexity of the results coming back to us, getting overwhelmed with data and figuring out how to handle it right for our patient. And the fact is you need to invest in infrastructure to be able to get them, handle them, and I think some centers or some docs want to, there's a feeling to just give up on it and just start empiric therapy, right? Like, I feel we moved into precision therapy, and now maybe we're sometimes moving a little bit away from it. It's getting too hard, and we can't allow that to be our practice, right? This is important for patients, and the ability to just embark upon a tolerable therapy where you have high likelihood of benefiting is so good for the patient. We cannot give up on the potential for precision therapy. There are more and more drugs, there are more and more biomarkers, there's more and more complexity, and so it requires education, it requires being informed. Yeah, it's hard, and it's worth it. And so, that's the reality. It's not gonna get easier. Maybe our molecular pathologists can make it easier on us. Maybe there are ways that we can have easier results. If only some of these reports would be simplified. Right, and so that probably is something that we can start to do. Just simplify things down for docs to say, look, lay it out for me. Don't make it complicated. Help me help the patient. When I say simplify, I mean that sometimes there are excess details or excess minutia or even excess markers on there that are just confusing the doc, right? On a 400 gene NGS panel, how many of those really impact the patient? 12 of them? Right, and the rest of them are just there for confusing us. And so I think we can still, it's great that there's a coverage determination for NGS, and now we need better guidelines on how to give these results back to doctors so they can help patients and not mismanage patients. I think we're making progress on that, but it's still, oncologists need to tell us what they need. Community oncologists need to tell us what's frustrating them, and then I think we can still make progress to make it easier for all involved to give good, precise oncology care. Some results will say, here's this really reliable, very targetable driver, and these drugs are available, and here's this fascinating other mutation, and you could think about this clinical trial. And the doc comes to me and says, well, that's interesting. Should I do the trial or the reliable FDA-approved drug? And it's like, pick the FDA-approved drug, okay? This was just there to make the report seem more interesting, And so that other stuff, kind of tone that down a little bit and focus on, look, this is on-label therapy, focus on the highlights, and this honestly risks confusing the patient and confusing the doc and confusing the care.
Yeah. I think that's really helpful feedback to have, especially if you get molecular pathologists and genetic counselors reviewing things. They might, like you said, go into the minutia of this one in vitro study, 10 years ago showed that this variant might have this effect and that kind of thing. And really, I think sometimes the reports are generated and then we don't know how it's read or what's interpreted. Do they actually read my whole report? Do they just look at the list? So I think these conversations are helpful between who's actually reading the reports, whether it's community oncologist or your colleagues in an academic setting, and what do they want out of the report and what are they getting and how much of stuff are they not getting. We've even had conversations about how trying to move it into our EMR to be more like a chemistry value. Mm-hmm. Looking at, for example, if you're following EGFR mutations or resistance mutations, there should be like a molecular tab, and you should be able to. There should be like a list.
Bing.
Of this day they have this variant, and so something that's not buried in maybe a scanned PDF in the EMR that's kind of hard to find. So I do think there's a lot of ways that everyone can work better about simplifying and making sure that the oncologists are getting the data that's important, and the patients getting therapy directed appropriately. There's probably a lot of work that can be done.
Patients can get the reports. They don't always prioritize that, but the motivated, sometimes anxious patient will pore over every little finding, and it can honestly slow you down. Patients don't appreciate it. They're an EGFR mutant cancer. They have resistance. They say, should we check for ROS now? And it's like, it doesn't work like that. You're EGFR or your ROS, and so. Yes, I can envision there's a day when there are oncologists out there that will say, this is frustrating me and slowing me down. I mean, there are definitely docs who are nihilistic about a lot of this. It's just led to a lot of negative testing. And I don't want us to get there. But short of that, I think we need to be sensitive to the burden we're putting on clinicians with these reports in a way of making them more streamlined and efficient so that really help us give good care.